Imagine you're lying in a hospital bed. You're vulnerable, right? And a thin, plastic lifeline is being inserted to deliver crucial nutrition straight into your stomach. But what if it goes just a fraction of an inch in the wrong direction? Well, that tiny misstep transforms a completely routine procedure into a catastrophic, life-threatening emergency. Today, we're diving into a fundamental medical procedure that relies entirely on this incredible, delicate balance of human anatomy and precise clinical skill.
Welcome to this explainer. Today, we are taking a clinical journey into the world of the nasogastric tube, or as it's commonly known in the medical world, the NGT. Now, behind this deceptively simple piece of plastic lies a fascinating and, honestly, high-stakes clinical protocol. So, let's break down the science, the hidden risks, and the meticulous anatomy required to actually keep patients safe.
Okay, let's dive right into this by looking at the very first decision a clinician actually has to make, choosing the right tool. Because, nasogastric tubes aren't just one size fits all. A large 16 French tube, for instance, is highly effective as a pressure release valve. It's great for draining or decompressing the stomach. And this is absolutely critical when there's an obstruction in the GI tract, like an ileus. The catch, it's pretty uncomfortable for the patient. Now, on the flip side, you've got the small 10 French tube. This one's much more comfortable, making it perfect for administering feed or drugs, especially for critically ill patients or those struggling with swallowing, also known as dysphagia. But the trade-off here is that a smaller tube is terrible for drainage, and it can be super difficult to aspirate. So right out of the gate, the clinician has to balance that urgent medical need against the patient's comfort.
Now, actually passing the tube, that is exactly where the science meets the art of medicine. There's this brilliant kind of wry piece of advice in the clinical literature for doctors attempting this procedure. It asks, have you asked the charge nurse from the ward next door? I mean, it perfectly captures the reality of the hospital ward, right? Ward nurses are the true experts at this stuff. They do it every single day. If a seasoned nurse has tried and failed to pass a tube, a less experienced doctor is going to have an incredibly difficult time. It really highlights that placing this tube requires a physical intuition that literally only comes with extensive, hands-on experience.
So how exactly is it done? Well, let's walk through the strict anatomical protocol. First off, the clinician puts on non-sterile gloves and an apron and grabs a new cool tube. Using a cool tube is actually a great little clinical trick because it makes the plastic slightly less flexible and a lot easier to guide. They estimate the length they'll need by holding it against the patient's head, measuring from the nostril to the back of the throat. Then, after generously lubricating it with an aqueous gel, the tube enters the nostril. But here's the crucial anatomical trick. You do not push it upwards. Nope. You advance directly backwards, following the natural curve of the nasal passage. Then, when the tip reaches the back of the throat, the clinician has to perform a really precise 180-degree rotation. This stops the tube from just coiling up in the mouth. Finally, the patient is asked to swallow a sip of water, and the clinician times every single push perfectly with each swallow, letting the body's natural esophageal mechanics literally pull the tube down.
And this brilliantly illustrates the sheer depth we're talking about here. In an average adult, the stomach sits roughly 35 to 40 centimeters down from the nares, or the nostrils. But you don't just stop right at that 40 centimeter mark. Oh no. The protocol dictates advancing the tube at least another 10 to 20 centimeters beyond that mark. Why? To make absolutely sure the tip is sitting securely, deep within the gastric pool before finally taping it to the patient's nose.
Okay, so once the tube is taped, you might think, great, the job's done. But actually, we have just reached the absolute most dangerous phase of the procedure. Confirming its position. Because think about it, if that tube has accidentally slipped past the vocal cords and gone down the trachea instead of the esophagus, it is now sitting directly in the lungs. And pumping liquid feed or medication into the lungs, that has led to preventable deaths. It's a massive deal. In fact, in the UK, feeding through a misplaced nasogastric tube is officially classified as an NHS never event. That means it's a serious, largely preventable patient safety incident that simply should never occur if the proper preventative safety checks are actually followed. So yeah, the stakes literally could not be higher.
So how do we actually prove the tube is safe? Well, we use some basic chemistry. To confirm we're definitely in the stomach, we have to draw up or aspirate some of the gastric contents. Since the stomach is naturally a highly acidic environment, we need an aspirate of at least 0.5 milliliters, and we test it right away on unhandled pH paper. What we're looking for is a highly acidic reading, a pH of 5.5 or lower. You've got to allow about 10 seconds for that color change to kick in. If it hits 5.5 or below, boom, you have clinical proof you are safely in the stomach. But clinicians still have to stay super vigilant.
Things like antacids or proton pump inhibitors can actually artificially increase the stomach's pH, which completely muddies the results.
Now, it is absolutely vital to talk about what we do not do anymore. See, for decades, a really common practice was something called the whoosh test. You'd inject a syringe of air into the tube and listen over the stomach with a stethoscope for a bubbling whoosh sound. But guys, modern medicine has completely debunked this. The whoosh test is absolutely 100% not an accepted method for testing tube position anymore. Why? Because air injected into the lungs, or even just the esophagus, can sound deceptively similar. So what happens if your pH test fails or reads above 5.5, but you desperately need to give drugs or feed? You've got to get visual proof. The position has to be checked radiologically with a chest or abdominal X-ray. You're specifically looking for the radio-opaque line that's embedded in the tube, making sure the tip rests safely below the diaphragm.
So, the crucial point here is that this supposedly routine procedure comes with some absolute red flags and contraindications. For instance, you must never pass a tube nasally if there is even a tiny suspicion of a facial fracture. The anatomical disruption means the tube could literally enter the brain cavity. I know, it's a terrifying thought. Also, if the patient has recently had upper GI surgery, you must get senior help. Pushing a rigid tube through a fresh surgical joint in anastomosis is just terrible practice. And honestly, even when it's done perfectly, complications can still arise. We're talking anything from general pain and esophagitis to severe issues like accidental tracheal intubation, retro or nasopharyngeal necrosis, and in very rare cases, actual stomach perforation.
Okay, let's move forward and see how this all builds toward recovery. When a tube has been used to relieve an obstruction, you can't just yank it out the second the patient starts feeling better. The removal has to be incredibly carefully planned and weaned. The clinical threshold for successful weaning is when drainage drops below 750 milliliters in a 24-hour period. We follow this really strict timeline. First, the tube is left on free drainage, checking it with 4-hourly aspirations. Next step, we cap it off or spigot it, but we keep up those 4-hourly checks. After that, it's left on a spigot only. And then, if the patient's body tolerates that stage while also taking in oral fluids, it is finally safe to remove the tube. But what if they struggle at any point during that timeline? The protocol demands the clinician take a step backwards. It's a really slow, highly controlled return to normal digestive function. So, what begins as just a simple length of cool plastic ends up becoming this high-stakes navigation through the hidden labyrinth of human anatomy. Every single centimeter advanced, every pH test conducted, and every clinical decision made carries the profound weight of a patient's safety. The next time you see one of these simple tubes, I guarantee you'll know the incredibly complex journey it took to get there. But it really leaves you wondering, doesn't it? In an age of robotic surgery and advanced AI, how many other life-or-death procedures in our hospitals still rely entirely on the delicate physical intuition of a human hand? Thanks for joining me on this explainer, and keep questioning the science behind the everyday.